So here's my outline about what we're going to be talking about. So a little bit is about introduction and what do you want to get out of rehab, which is already she kind of scratched that. Treatment planning is basically talking about what is most important to get done during the time that you have with your patients, and then how to carry over that treatment plan to your caseload. And then we'll talk about some case studies and then we'll wrap it up from there. So in terms of introduction, I just wanted to try to get an idea about what levels people do we have kind of participating right now? Like, have you already had your fill? Have you already had zero fills? Have you had fourth of fills? Are you about to graduate? So just kind of trying to get an idea about that so I can kind of try to tailor the rest of it to you guys. So I'll give a minute or so.
And I'll chime in
If people
too. I think you all will have the opportunity to interact via the Q&A button at the top. If you click that, and then there will be an open ask a question. Instead of a question, you're going to answer our question and say where you're at currently. Thank you.
And if you want to also comment, have you done your outpatient? So I know again, like doing like an inpatient one versus rehab versus like neuro, and then actually like outpatient rehab or physical therapy, that is also going to kind of maybe affect how we're thinking this. So I'm presenting more in terms of like an outpatient. So while you guys are answering that, I'll give a little bit background of my specific clinic. We have about 15 therapists who are OTs and PTs in our clinic. And so we are not a one-on-one clinic. However, as we all try to do, we want to give the experience of one-on-one in terms of the quality of what we're giving them. So, trying to ask the appropriate questions, having the, active listening and stuff like that. So anybody answer about what a field they're in? I can't see it, sorry.
I posted a discussion, but I'm not sure how the feature works. It's our first time using it. But I do know we have a lot of 2026 graduates that are joining us today.
Okay. All right. So I think that most of you had done your FL. So if you figure it out, I would love to have some participate. You'll see why also like written on my slides. So most of the time, this is like, what do you want to get out of rehab? Obviously, the first thing that people always say is, I just want to feel better. They're usually in a lot of pain, and that's why they went to the doctor in the first place. And the doctor's usually like, hey, go to PT, it'll fix you. Then they also want to be independent with ADLs, like getting back to the things that they do every day, but they couldn't because of either pain, their injury, whatever it is. A big component is also, I want to return back to leisure activities. So usually they're like, I want to return back to running. I want to return back to, playing soccer with my league and stuff like that. Or, I want to go back to going to the gym. And I can't do that because my back is killing me. So that's a very strong, convincing factor of why they're here. Overall, they want to get stronger. And then, for certain people, they want to get better balance or gait, or not having to use their assistive device or brace or whatever they're stuck on right now because of their injury. So what I always ask my students and stuff like that, and the new therapists that come to my clinic, is like, if you were a patient, what would you want to get out of your experience at a clinic? So I listed a whole bunch of stuff here, but I also want you to take the time to think about that too. And it doesn't have to obviously be what I'm saying here, but from my experience, from what my patients are telling me, is that the plan is tailored to me. I'm not just doing 3 sets of 10 because it's a thing to do on online or something like that. So, but it's like I'm doing these exercises that are specific to my goals. So, and then also like, the rehab is challenging and progressing me appropriately, because that's a big one as well. You have a very attentive therapist. They give me a home exercise program. You'd be surprised about how many people actually don't have a home exercise program. So they could be going to PT or OT 2 or 3 times a week. But if you really think about it, we have 168 hours in a week. If you just go, let's say it's an hour, every single time you go to PT or OT, minimally it's 1 or 2, maybe 3 hours a week. So that's 3. What are you doing for the rest of the 160 something hours after that, right? So you want to have some carryover from what you learned, what you got out of your experience in PT or OT, and you want to carry it home, because I mean, I'm sure they all love us, but they don't want to see us here forever either. So they want to become more independent, to have that 168 hours back to them and not be in pain and get back to whatever they want to do. Knowledge. they want someone who knows what they're doing. The one thing I actually came up, I had an eval the other day, and I was like, I would, another story, but they're like, well, when I came in, they said, oh gosh, this is the first time I've ever seen this. I'm not quite sure what that really instilled, but like if I had an injury, I don't want my therapist to be like, hey, I've never seen this before, but that's really cool. Which is, I'm glad you think it's cool, but I kind of want you to know what you're doing as well. So that maybe the confidence had, a little bit shaken there. Empathetic, obviously. I don't need their pity or anything if I was the patient, but I want them to understand where I'm coming from in terms of this. So that goes into understanding what I need. And honestly, if you make it fun, it also is a huge like plus to that as well, right? Because it's like a class. So if you go to a class, yeah, you're getting the knowledge out of it, but if you really enjoy it, you don't mind going back either, right? So treatment planning was the point. So it obviously addresses the limitations that prevent the patient from improving or recovering. And then like you want to provide services to the patient that they cannot do at home independently. And they need your skills and knowledge of like why we went to school, right? And then you also want to continue to improve or foster appropriate healing time frames and just like what to expect in terms of, the protocols, so they look to you for that guidance, and then you are like the person who helps plan it. So going into a little bit of case studies, and you'll see why I'm doing this. So I have 5 of them. So the first one is the knee, right? So you have a patient who's a right ACL reconstruction. They also had a medial meniscus repair and MCL sprain. Arrives to you 5 days after surgery. So when you do their evaluation, you find obviously they have increased pain and swelling. Their range of motion is not the greatest. They're actually lacking 10 degrees of extension, and they only flex it to 45 degrees, which is not the greatest. They can't contract their quad. They're not working well. They're on crutches and lock knee brace. And actually, I didn't put it in here, but if anyone's dealt with a medial meniscus repair, they usually are non-weight bearing. So you had this patient, right? Because it can be a little bit overwhelming, like, especially if this person's like very sensitive to pain and they're going to be like, oh my God, I can't do anything, right? So, what do you want to get done on visit number 1, right? You're looking at all the things that we've measured, you're looking at all the things that they're telling you, you've gathered their goals, we've shared our goals, like as a rehab specialist, we've shared our goals for them, right? But if you only have, the evaluation took about 15, 20 minutes, right? So let's say you have an hour session, you have 30 to 40 more minutes left. What do you want to get out of this? What is the most important things that you want to teach them until and they can do until visit 2? So again, if the chat function is working, you're welcome to kind of like throw out some stuff. I'll give a minute or so, and then I'll kind of talk about what I would do in that case. Um, And then also, I kind of gave it away already, but then like, what are the precautions or contraindications that will affect your rehab at this point in time? So just look at the first line about what kind of surgery they had. Is there any precautions? Are there any contraindications? So what you can do, and then what are like, for example, 3 key things that you want to get done on visit number 1 that they can keep on doing at home until visit number 2.
And Irene, I'll let you know as the answers come in. We did get it figured out at the beginning. We got a bunch of
Yay!
submissions around a lot of first year, second year, outpatient rotations. So this is important stuff for them. So we'll give everyone a minute. Looks like there's a little bit of a lag time, but
Yeah. Of course, I start with a wonderfully complicated case, but
looks like we've got 1 vote for knee extension as an
yes,
objective.
absolutely. It is not looking pretty with -10 degrees here.
No, that's for sure.
I've actually the cases I've listed are all cases I've had. So So we'll go off of that one. Yes, one of my number one objectives is to get that extension back. So consider what can prevent that extension, right? I'm looking at pain. I'm looking at swelling. I'm looking at like the person being afraid to actually move, and they keep their knee bent, and that's what also doesn't help, and it keeps it a little more contracted, limiting their extension. They don't know what to do. So they may be doing other stuff like they're walking a lot, being like, yeah, the doctor told me to move around. It's like, okay, so, but what else do they say? So going kind of tying into number two, it's like usually, are there any precautions or contraindications for a regular ACL reconstruction or medial meniscus meniscectomy versus repair? So if you're not familiar with that, I'll just talk about that very briefly. Is that the meniscectomy is pretty straightforward, right? They're kind of cleaning it out, making it nice and pretty again. There's no precautions for that. The repair, usually they're on weight bearing. Depending on the surgeon, they could be very conservative and not make you weight bear for 6 weeks, versus if they're a little bit more aggressive, or maybe it's a small repair, you can weight bear after 4 weeks. So keeping that in mind, that might actually affect what kind of exercises you give the first 4 to 6 weeks, right? I know some people are thinking, oh, I can do some stretching. I would do some stretching. I would stretch out the back of my knee in terms of the hamstrings and the calves. I need to get back the quad contraction, because without that, but also it ties into my lack of extension. So you see how like I'm kind of like puzzle piecing around like what what are important things that I need to work on, but what's the step before it if it prevents me from doing my main thing? So the extension is very important. I need to get that back to basically move on to anything else. Honestly, it won't work very well if I don't have full extension to contract my quads. I won't walk well, and then I'm not going to be discharged on my brace. I'm not going to get unlocked, et cetera, et cetera, et cetera. So that is kind of like where I would start with. I would also talk about the whole surgery too. A lot of people don't know what happened. They don't understand mastectomy versus repair either. They don't understand why they can't walk on it. So kind of like, patient education would really help with talking about that, as well as making them understand it, and then you'll have better compliance. All right.
And Irene, we
So,
got we got two other answers that were totally in alignment with what you just said. So
yay.
exercises help with knee flexion extension, but also activating that quad, and then
Mhm.
decreasing that pain and swelling. And then precautions were around pain and weight bearing status and that sort
Yeah.
of thing. So
Awesome. That is extremely awesome to hear that. I think also one last, I'm gonna go on with that. Okay. Number two, the case study number two. All right, so this patient comes in. It is a left fourth finger PIP fracture dislocation. Has surgery 3 months ago to have the fracture pinned. But now that you've seen him afterwards, the pin is long gone. Probably got out about 8 weeks ago, 6 to 8 weeks ago. And let's see what they look like. So the range of motion is not great. Okay, so I've listed basically the left affected finger, like the left forefinger, so you cannot extend fully. They're extensions of 15 degrees, and they can only flex to 45, whereas the right hand or normal hand, it can fully extend and can fully flex to 75 degrees at the PIP joint. If we're talking about DIP, they also still can't get full extension, so they're lacking 5, and they can only bend 30, whereas their other right hand could go from 0 to 45. Grip strength, as you can see, it's basically half. And then here's a good question too, which is your dominant hand? So I also have to keep in mind, like, okay, if this is not my dominant hand, I mean, most people aren't going to be exactly the same strength from right to left unless they're very cognitive of that and works equally. But most of us, like, if I'm right-handed, my right hand is going to be a little bit stronger in terms of like grip strength versus my left. But even this is a little bit more than I would like. Seeing this, so you know that they can't fully extend it, you know they really can't flex honestly, and their grip strength is not great. What kind of ADLs would you expect this patient to have trouble with? All right. And then with that, what kind of exercises would you do or give them? What kind of manual therapy would you consider? What kind of modalities? Um, and anything else that you wanted to talk about. So I'll give a minute or so. And just for reference, this was the one that apparently when he went to a different clinic first, they said, "Hey, I've never seen someone come in with a pin before for a finger fracture. That's really cool." And I was like, so this is my tiny plug for hand and finger and all that kind of stuff. Because I know that in PT school we go over this, but then most outpatient clinics, they don't actually have you see them as much, especially if you have OT. So my clinic actually has OT in the same location. So we have very, very talented people who specialize in like the finger, hand, wrist, elbow, that kind of stuff. So a lot of the PTs kind of forget how to do hand therapy after a while. But especially if you want to get into like sports or like even with neuro, honestly, you're gonna have to you should probably keep up with it because it will serve you in the long run. That's a plug.
We've got an treatment just in manual therapy, working to get into further flexion and extension is tolerated.
So I
That's all.
know again the other place was doing so here's another one that I would like to kind of mention too. Um, if the person went to a different clinic first, I always like to want us ask, is your reason why that you stopped? And if it's something like negative, you don't have to share it with me. This person had changed insurances and that clinic didn't take it anymore. So, but he said I had a positive experience otherwise, beside the therapist saying, "Hey, I'd never seen this before," but otherwise it was fine. And then I always ask them what kind of things they do with you there. So then, like, you can kind of build off of that because depending on how they look, depending on how they progressed and stuff like that, you can either modify a little bit and continue that kind of like plan of care, or if that one's not working, because maybe that's why they left, because they're like, I didn't really get anywhere with there, and I just wanted a fresh start with somewhere else. And so you can kind of see what they did over there, and you can kind of revamp your plan. So again, listening to their goals, seeing what worked or didn't work, because they already kind of did that for you. They showed you what didn't work. Um, so with this one, especially when they can't extend or flex, this extension's not that I mean, not that as important in terms of ADLs, but the flexion being so limited, they are going to have a ton of trouble with gripping. So anything that requires gripping, like carrying grocery bags, opening a water bottle, opening jars, meal prep, even just like lifting or carrying like dishes and stuff like that. So like anything that requires a lot of stuff with their hands. Again, if they're right-handed, and it depends on which finger it is, they might have trouble with typing, like writing stuff. Like I had somebody who had trouble with writing because of their finger fracture, and just lifting in general. So I would there's no like great priority for that unless again if it's a dominant hand and it was more like an index or like a middle finger and like oh I have to do a lot of writing I can't write. But like for this case I really wanted to work on range of motion stuff, active and passive, that they can do at home especially, right, to have that carry over after I work on them. I actually introduced paraffin to him, which I think I don't know if a lot of people have it in their clinic, but I find that it's very effective in terms of kind of heating and warming up the joint, helps with some swelling, makes them feel good, and then I can do like some passive or active range of motion and kind of work on them with them in a little bit more comfortable state. And then, like I said, I gave them a lot of like self mobilization, self like range of motion kind of stuff. Um, I gave them just one strengthening thing that the other place didn't give them yet. So that's where I would have gone with that first. Okay, so case study number three. Everyone's probably going to get a hip replacement in their life. So this person is left total hip replacement, anterior approach 2 weeks ago. And so their current complaints is pain at the left groin. So it's a left total hip replacement. They have pain at the left groin and anterior hip, lateral knee, and the right heel. They have weakness and decreased endurance during ambulation, and they had decreased balance with squatting because he almost fell over petting his cat. So his objective measurements include, so his left hip flexion was 104, is kind of stiff and painful. External rotation only went to like 30 degrees. External was only to 4. And as you can see with the comparison, the right hip had about 120 degrees, 55 and 18. So his ADL deficits, he can only walk about 5 to 10 minutes. Stairs is kind of hard. He only can tolerate like one flight. He had to do kind of like a step by step manner. He couldn't do step over step. And obviously, difficulty with squatting to sit in a low chair. I think he actually had a toilet raiser as well because his toilet in his apartment is kind of low. So things to think about with this one are what are the hip precautions for anterior versus posterior lateral approach? And then what kind of exercises can we give to them to work on the walking and stair negotiation tolerance? So I'll give a minute or so.
We got one for no hip flexion greater than 90 degrees.
Is that for anterior or posterior?
Must be for posterior. I'm going to say, I don't know. I don't know what they meant, but that's what we got.
I also will comment that I think when I first started working in outpatient to now, which is almost like 15 years, I think I've slowly seen more and more anterior approaches versus posterior lateral. So the traditional, precautions for like, the no knee flexion and the adduction and like the eye, or that kind of stuff, um, kind of goes out the window because I don't have to really worry about it anymore because I don't see that many posterior lateral approaches anymore. And the precautions for anterior approach, unless you do like ballet or ballet dancing or whatever, which I have had someone with an anterior approach, um, you won't really get there in everyday life anyway. So I don't have to be as concerned about that. Um, so the precautions for anterior for this particular patient is he cannot extend, and he shouldn't external rotate, and um he shouldn't like abduct. So I mean that kind of stuff like you don't really have that combination anyway. The posterior lateral approach is a little bit harder, and I've had people dislocate their hips many times because they kind of forget. Um, so with this one, what I wanted to point out was that yes, he has the usual pain at the left hip, which we expect, right? Lateral knee, I will see a lot of that, but then think about why you would see that. And then I'm seeing the right heel pain. So that tells me that he is walking, right? He's walking, but then he is weight bearing a little bit more onto the right, obviously to favor the left one. So what kind of exercises can I get him to do that will equal it out so he doesn't put as much weight on the right side? There is to note that he's still using a cane. So, I mean, using a cane, yes, it's supposed to help unload the side that it's supposed to help, but that also means that you're kind of putting a little bit more pressure on like the side of the cane. So maybe that's another reason why he has a heel pain. So I gave him actually calf stretches. I really want to work on glute med stuff, like glute med, max, that kind of stuff. I actually saw this patient before he decided to have the hip replacement surgery. He was trying to weigh off on that because of work and stuff like that. And then he finally bit the bullet and he was like, I have to do the surgery because I'm just in too much pain. Um, but a lot of like glute med work, a lot of like glute max stuff, and just like overall balance and core. But and I think just learning like what his tolerance is in terms of like glute med stuff, because apparently the home PT, for example, gave him sidestepping, but then he was super sore the next day. So whereas the exercise totally hits where we want it to work, but at this point of his recovery, it was a little bit too strenuous for him. So I have to know that. I have to take a step back. So then I have to kind of recalibrate what kind of things of glute med stuff that I can do that's not actually going to be sidestepping. So just keep that in mind as well. Just be also always have like a plan of like, okay, if you try this one exercise and the patient is like, oh, that was great. I feel, this is easy, blah, blah, blah. Like, how can you bump it up real quick? Or I can't do this. This really hurts. And how do you regress it very quickly? So case study number 4 is a shoulder. Okay, so this patient initially injured his left shoulder with a weightlifting program. He was trying to progress his weights, did it way too fast, and then he says, "I thought my shoulder was just sore, and it just never went away." This is about a month ago. He injured it. Went to MD, who performed imaging, negative for anything. Nothing's torn, nothing's dislocated, nothing's like sore or anything. No nerve damage. The range of motion within normal limits. Everything is equal. It's probably better than mine. His left shoulder MMT for flexion, abduction, and ER is a three plus out of five with pain, whereas the right side is all 5 out of 5 and pain free. When I do my special test with him, he is positive in speeds, biceps load, painful arc, and near. So, knowing all of this, how would you design the program? Right. So obviously, range of motion is going to be, I don't need to address that because the range of motion is fine. It's equal from right to left. Where I do see the biggest deficit is obviously with pain, but then also with his decreased strength. So what kind of muscle groups should you work on to address those listed deficits? And also, what kind of things would you tell this person on activity modification? Give me a moment. I think a little hint is like with a special test, think about what does that test and then why is it positive?
Looks like from a muscle group perspective, we have upper, middle, lower traps. All I've got for you so far.
Okay. I agree. I personally would maybe work a little bit more on lower traps and middle traps, not so much upper. Only because when for example, when I did his range of motion and he raised his arm and he did this. So I can already see that his upper traps is really active and maybe his lower and middle traps is kind of like, taking the back seat here. So, but that also might correlate with my positive near. So positive a near is an impingement test. So that coupled with, some rotator cuff like irritation, which also causes some like biceps, irritation, which is why his speed and bicep loads is a little bit painful. So I need to unload the front of his shoulder. I need the back of his shoulder to work a little bit more. So as my MMT, like all of that is painful. So anything overhead, he says I can do it, but it really just hurts, and I kind of avoid it. Um, that's my advice on activity modification. Don't reach up there unless you have to. And also I try to tell people, because the number one thing is like, do I have to stop working out? I was like, well, if it hurts, you shouldn't do it, right? But I know that a lot of people are like, but I can't not work out, which I respect that, right? But I want you to do something, but I don't want you to keep on hurting yourself. So that's very important on advising them what they can and cannot do. Even though this is not a post-op case, they still need to know because they can actually be doing something every day that keeps on irritating them, and that's why they haven't gotten better even after a month later, right? Um, so advising them on what kind of things they should avoid for now, and then helping them decide or, kind of guiding them, when can you start to introduce that again to kind of test it out and work on that range of motion and strength again once like the overall pain and the baseline strength has gotten a little bit better. I want to work on his rotator cuff. It is kind of weak. I also want to work on just the periscapular like stability. So when he shrugs his shoulder, it doesn't just go up into impingement and then it predisposes like the biceps to be kind of irritated and stuff like that. So this is going to be not just a one and done kind of thing. It's going to take a couple weeks to kind of neuromuscularly re-educate how this person should be lifting their arm, how this person should be, um, you know, doing the exercises. Like some of the exercises he could be doing like rows, I would give him rows too. But if he's rowing and he's shrugging his shoulders up like that, think about like, okay, where is the purpose of my row supposed to be? And what am I seeing right now, which is kind of perpetuating his pain. So that's where I kind of want to see what he's been doing. What can I take out for now and put on the back burner? What can I make better and help facilitate? Last case study is the foot and ankle one. So I had a left peroneal tendon repair, and that's actually a revision. So this person actually had surgery 5 months ago. It was actually something happened at work. I think he does a lot of like lifting and carrying at work, and then all of a sudden he was like carrying a very very heavy box up the stairs, and felt something just like popping give in his ankle, and it was in very very much pain. Peroneal tendon repair was fine. He went to rehab, and then after about 6 weeks, I think when they started to ramp up what they were doing, he started getting pain again. Um, the other PT was saying, "Well, it's okay. You kind of have to kind of work through it a little bit because it's weak, and you just had surgery. And you were just in a boot," which all makes sense, yes. Um, but again, this is what the patient was telling me. They didn't really modify or decrease what they were doing overall. He went back to the doctor who did another MRI, and he actually retore it. And he actually retore it worse somehow. I don't even know how. Had surgery. This happened 2 weeks ago, so they revised it, and then he finally got cleared to start with PT with very very strict precautions and contraindications. So because this is a revision, the doctor was very much more cautious in terms of when to clear him for weight bearing. That was a huge thing that she actually put on him that wasn't on the first one. So instead of like non-weight bearing for like 4 weeks, he was actually non-weight bearing for like 8. So if you had this kind of patient, and it doesn't even have to be this patient, right? So you could have a patient with a different body part, but it's basically like a revision or a redo of the original surgery that they did. How would you approach this patient differently versus like if you just saw them for the first time, right? So what kind of things would you consider, or how would it change how you approach them?
I have slower progression and ensure strength is there before progressing.
Yeah, definitely, definitely. So, I mean, the surgeon already kind of indicated that as well, obviously, which is why she did not clear him to weight bear until after 8 weeks versus 4. I also definitely tread cautiously, you know what I mean? Confidently, but cautiously about like, how fast we are progressing. And I really, and this is also a fine line too, because you don't want to catastrophize like what happened, but you also obviously want to be mindful of their pain, right? So you don't want to like really, really focus on like, well, is it like an 8 out of 10 or is it like a 5 out of 10 or like what level can we give this? Because I don't want to get, I know they're in pain, but I don't want to bring that much focus to it because I want them to also kind of focus on what they can do and what they can't. So keeping that in mind, like I want to show them like the things that they can do, it's not going to hurt this progression. So yeah, I definitely took it slower. Um, the swelling was the big thing, so we couldn't do too much anyway. I try to keep him distracted and doing more like, upper body and core stuff, and even just hip stuff that I can do on the table. Depending on the insurance, you might actually want to do one time a week until they can do weight bearing. So that's another thing that you have to kind of keep in mind in the back of your head. What kind of insurance do they have? And like, will this affect you? Because if for example they only have 20 visits a year and you use up what two times 8, 16 visits, I didn't even get off the table yet. Is that worth it? I kind of want to save a little bit more of his visits for when he's able to do more on his feet, which can translate him into like going back to work and all that kind of stuff. So, but then you have to also emphasize a home exercise program, updating that, giving them clear directions on what not to do and what to do, and then like just making sure you keep like good communication if they're only seeing you once a week. So that's how I would approach this one as well. So what's the point of all this besides talking about all my patients? Do you notice a common theme to the answers that you're given for these case studies, right? And then what kind of things would require more of your time, expertise, and feedback? Right. And then also on the flip side is what kind of things can the patient do independently with, right? And you want to translate what kind of things that require your absolute one-on-one. Like, I need that quad to fire. They're just squeezing like the bejesus out of your glutes and not doing that. So I am literally sitting here, pointing here with Sim, being like this, and having you look, this is where the muscle you're supposed to be using versus like you squeezing your butt and that's why you can't get your knee straight or even contract your quad. So like eventually if I spend the time now, right, that is going to pay off in dividends later on when they can do higher level stuff and they can become more independent with and with their home program. So knowing that too is probably how you can kind of plan to overlap with patients, right? I mentioned before that I don't work in a one-on-one clinic. Um, I kind of find that personally a little bit more fun too. I think like the environment that we bring to our patients is it's a very open plan, and so a lot of patients can kind of see what each other are doing. But then a lot of them are very encouraging to each other, so they kind of see like, oh, this person's doing that. Will I be able to do that eventually? I'm like, yeah, of course. But let's like we're focusing on this. But yes, that's our goal. Right? You want to do the fun thing later. We gotta eat our vegetables before we can have dessert. So like kind of thinking about like if you have Mrs. Jones coming at 8 and you have like Mr. Smith coming at 8:30 and then you have somebody else at 9. In between those times, right? What do you want to get across? What's like the number one, two, three things that you want to definitely go over with them or that you need to do with them first before the next patient comes in and you give them stuff they can do more independently. That's how I would start to think about planning your schedule and managing the time management and stuff like that. Um, my clinic, I would have a little bit more say in terms of like where I can put like where I can schedule my patients as well. So I can if I know that like this person requires a little bit more hands-on, maybe because of the type of surgery they have. I've had people because it's like a stroke kind of thing, so I need to be there. They're a fall risk, or even like emotionally, they need a little bit more time because they can't be left alone too much because they go off on a reservation and they're doing like exercise they're not supposed to do. So I have to keep a little bit closer eye on that. So if I have too many of like the more hands-on patients back to back to back, it is going to make my schedule a little bit harder. So then if I am advising when to schedule, I can kind of gently suggest them to schedule at a certain slot versus another one as well, especially if their time can allow for that. So there's all these different like things that you can think about beside like just getting your day done, but it's like everyone's not going to be the same person, right? And then how you react to the injury versus how another person with the exact same injury is going to react totally different. And I have that example right now. Like I have an ACL reconstruction. One person is kicking ass and she is doing everything great, listens to me perfectly, and the other person's like, I can't move, I'm in pain, I don't want to do anything, I'm gonna break the repair. I'm like, well, if we're going to break the repair by doing quad sets, we have a bigger problem, but that's not the point. But you can do it, okay? So let's get going. So just stuff to consider like that. I think I actually kind of talked about that. So how to plan the schedule, other things to consider is like, is it weight bearing versus non-weight bearing? Is there a language barrier? Um, in the city, obviously there's lots of people who do not just speak English. I've actually had people come in who only speak Mandarin Chinese, so that might take a little bit more mental time because I'm pretty fluent in there. But I also had to make sure that like explaining it more. If it's something very complicated, I'm starting to use like Google Translate. But then do you also have other additional support staff like rehab aides? Um, and then like we have, like I said, we have a very open floor plan we are always supportive of each other too. So it's like if I have my hands on somebody else right now, but I'm noticing that like John over there is doing something wrong, like if the aide is like busy with something else, and one of my therapists is, we help each other out all the time. So then they can jump over and be like, hey, Irene doesn't want you to do it that way. Let's try it this way, right? So it's like kind of like that kind of thing to consider. I talked about the emotional versus like the physical dependence, and then also like equipment and space availability, right? So you don't want to be that person that has 6 people and taking up all equipment that everybody else needs while your coworkers are stuck with like a ball. So just kind of keeping in mind of like, all the things. There might be other things too, but that's the top ones that kind of come to my mind in terms of like scheduling and like time management. So other pearls of wisdom that I want to offer is don't panic. So sometimes when people see like every single slot scheduled, or like, oh my god, I have a double right here. I don't know what to do. This is more than I've ever handled. Like, don't panic. Take the time to review the schedule at the beginning of the day, kind of break down what every person is here for, and write down what do you want them to gain out of this particular session today? Like, what's your goals? And yes, it might change a little bit because they're walking in, they're like, I can't do anything. I just did this the other day and now I can't move. Okay, what's my plan B, right? And then ask for help, especially if you're in a clinic that has more than one like therapist. Ask for help is never a sign of weakness, right? It is also, I think it's a sign of maturity in asking for help, because you want to make sure that they continue to have the best experience. And if you're a little bit too busy, or if you're a little bit overwhelmed, then you can kind of like tag team with your coworker to be like, hey, now you have two for price of one. We're both going to help you today. You know what I mean? And they will never be upset with that. I talked about, taking the time at the beginning of your shift to review it. I feel like um, sometimes if I'm running late to work and stuff like that, I don't have that time. I get thrown off as well. So I come in an already chaotic state, and then I just kind of that chaotic state kind of stays throughout like at least the first half of my shift until lunchtime. But like if you arrive 10 to 15 minutes before your time, take a time to look at your schedule, plan out a couple of things that you could do with each person, and that will also calm you down as well. Having alternatives to the payment treatments, keeping the patient in the loop. I think that's a really big one too, is that you can be very busy, but if you just tell somebody, hey, I'm going to have you do this one exercise. I'm going to keep my eye on you. However, Mrs. Jones would just want you, she's about to leave. I'm just going to talk to her real quick about something, but I'll be right back. That simple communication is all that takes to be. And so you just taking off for like 10 minutes and the patient's like, I'm done with my exercise. I don't know what I'm supposed to be doing now. And now I feel neglected. Now I'm like, I could be doing something wrong. You know what I mean? So it's like, in that little thing of being like, hey, I'll be right back. I just have to go wash my hands, right? Great. I love that you're germ free. Come back to me later. Or like, I know that you're not 101. Um, and Mrs. Jones is about to leave. I'm given 2 exercises, but I know that Irene's always watching me, or somebody else is watching me as well. Then I feel comfortable with that as well. And then lastly, it's okay not to know something, and you just have to fake until you make it. So then know what you're here for. If you don't know exactly like what to do first, just figure out 1 or 2 things of what you can do that won't hurt them, and then later on you can go research it. So, like, I know that when I was starting out, that was a big thing with me. Like, I would have these very complicated like surgeries, or surgeries that I've never heard of really, like letter J or multi ligament like the knee dislocation. I'm like, okay, so all their ligaments are torn in their knee. What do I do? I've never seen it before. And so like I would have to kind of be like, okay, what structure are affected? What can I do that I'm not going to hurt anything, and get through the session, and then go and research it and talk to my coworkers and boss and stuff like that. So it's okay to not know something. And it also applies to if the patient asks you a question, it's okay to say, this is what I know about that. However, I want to take some more time to think about it and give you a better answer next session. That's a great answer, and then they won't feel like, "Oh, she doesn't know." You know what I mean? They're like, "That was a thoughtful answer, and she's gonna keep on thinking about it for me, he or she," right? And that's kind of cool. I appreciate that you're sharing that with me. It's all how you say it. Just like Allison was talking about earlier. It's like almost like a perception of like saying that there's that saying 2 of the same things. I'm gonna take some time to think about it and give you a better answer next session, versus I don't know what you're talking about. I've never heard of that before. Which answer you do want to hear? I don't want to hear the second one. So I'd rather you tell me what you do know and you're going to keep on researching it and tell me next time a little bit more than you just telling me, I don't know anything. I don't really care to think about it more, actually. So just little things that kind of keep in mind that can kind of make your life a little bit smoother when you're treating.